Good morning. In this talk, I'll be discussing self-administered Bascule maneuver for the management of posterior semicircular cupulolithiasis. What is posterior semicircular cupulolithiasis? Here, the otoconal debris is not free floating. The otoconal debris, which normally remains embedded in the utricular macula, gets disengaged and becomes adherent to either the short arm or long arm side of the posterior semicircular cupula. How it is diagnosed? In a patient with positionally triggered disease spells, if the Dix-Hallpike or half Dix-Hallpike test elicits a persistent upbeat ipsitorsional positional nystagmus of more than 1 minute duration, it is by the criteria of Barony Society laid down in 2015 is just necessary to diagnose posterior semicircular cupulolithiasis. However, an important corollary to this nowadays is that we need to do a inversion test. Why inversion test is required? Because a posterior cupula has two surfaces towards which it can deflect. If there is a excitatory deflection towards the deflection in one direction, a 180-degree turn in the position of the cupula would cause the inhibitory deflection in the other position. Say, for example, this is a case of right-sided posterior semicircular cupulolithiasis. The right half Dix-Hallpike test causes the excitatory ampulofugal deflection of the posterior cupula, leading to upbeat right torsional positional nystagmus. If the patient is positioned to left lateral recumbent with nose down, there would be an inhibitory posterior cupula deflection, and that would lead to downbeat and left torsional positional nystagmus. This is called the positive inversion test, and this is nowadays essential for diagnosing posterior semicircular cupulolithiasis. So, with that anatomy in the background, we start with this patient who is a 32-year-old male, came with a history of 2 days of positionally triggered disease spells. The half Dix-Hallpike test, as you see, is being done here with the head rotated 45 degree to his left. The occiput lands on a pillow which is sufficiently thick to anti-flex the neck around 30 degrees, making it a left half Dix-Hallpike position. After a short latency, you see a left torsional upbeating nystagmus, which is persistent. So this is a excitatory nystagmus caused by the ampulofugal deflection of the left posterior cupula, weighted by the cupulolithiasis if the nystagmus lasts for more than 1 minute. So what to do if it lasts more than 1 minute? The next thing to be done is inversion test. In this patient, right lateral recumbent with nose down would be the inversion position. And what do we expect if it is left posterior semicircular cupulolithiasis? Then the cupula would be positioned 180 degree to the opposite side. So what will happen? The nystagmus will become downbeating and right torsional. This is the inversion position, right lateral recumbent with nose down. And indeed, the nystagmus is downbeating with the upper pole of both eyes torsionally beating to the patient's right. Once a diagnosis of posterior semicircular cupulolithiasis is done, what is to be done next? The Bascule maneuver. Here, the patient is seated in short sitting. Start. Start the Bascule maneuver like this. The patient has got left-sided posterior semicircular cupulolithiasis. तेजी से इसी पोजीशन में लेटो. गर्दन ऐसी रहेगी, पैर नीचे, पैर नीचे, पैर नीचे। 15 सेकंड तक इस पोजीशन में रखूंगा मैं आपको। Will be kept in this position for 15 seconds. अब तेजी से उधर जाओ पूरा, गर्दन ऐसी, हाथ बीच में मत लाओ। 15 सेकंड इधर रखूंगा, ये हाथ इधर रख लो, इस हाथ से उठाओगे जब उधर जाना है तो 1 2 3 बोलूंगा तब इधर फेस अप है, उधर फेस डाउन होगा। 1 2 और 3 फेस डाउन। 1 2 और 3 फेस अप। यहां तक, यहां तक, यहां तक ले जाना, इससे यहां टिकना चाहिए, नीचे टिकना चाहिए। हाँ, और जितना तेजी से करोगे उतना जल्दी ठीक होगे। 1 2 और 3 फेस डाउन। वन टू और 3 फेस अप। अब मैं हाथ में लगाऊंगा, आपको ठीक ढंग से करना है। यू हैव टू डू इट ऑन योर ओन एज आई टोल्ड यू। मैं 15 सेकेंड हर पोजीशन में रखता हूं। 1 2 और 3 फेस डाउन। One, two, and three face up. किसी पोजीशन में तेज चक्कर आए तो मेरे को बताना। 1 2 and 3 फेस डाउन। वन टू एंड थ्री फेस अप। One, two, and three face down. One, two, and three face up. One, two, and three face down. Quick. One, two, and three face up. Quick. One, two, and three face down. One, two, and three face up. One, two, and three face down. And now this is your last time. जितना तेज कर सकते हो करना। One, two, and three face up. So almost we have done it 10 times on face up and 10 times on face down position. And we now make him to short sitting. And at that time you have to be careful that you don't fall backwards or forwards because of position. Better. Stop. So this maneuver is dependent and leveraging the inertial forces which are generated in the right anterior and left posterior, that is RALP plane, and these inertial forces, they are used to disengage the otoconal debris from the posterior cupular surface. So whenever you have done a maneuver, it's important to do a positional retest. In my clinic, in my practice, I do it 1 to 4 hours later and preferably on the next day. The patient was called after 4 hours and the left half Dix-Hallpike test was repeated. The position was maintained for full 1 minute and recorded. With the head rotated 45 degrees to the left, the occiput lands on a 4 to 5 inch thick pillow, anti-flexing the head 30 degrees. And as you can see that during 1 minute of observation, there was no elicitation of any type of nystagmus and the patient is absolutely symptom free. So, whenever some new maneuver is developed, it's important to know its history. The Bascule maneuver was first used by the great Paolo Vanucci, an audiologist who practices in Florence, Italy, to treat anterior semicircular canal BPPV. In the year 2017, Giacinto Libonetti used it to convert the apogeotropic posterior semicircular canal BPPV into the typical periampullary variant with the geotropic torsion. This was the intracanal migration from the non-ampullary arm to the periampullary location. In Andrea Castellucci and his colleagues in Italy and Switzerland, they developed this to treat the posterior semicircular cupulolithiasis. And here they reverse Simon maneuver and the Simon maneuver are done alternatively in quick successions and very briskly. At least 5 different types of posterior canal BPP variants can be addressed. Number one, the cupulolithiasis on the short arm side. Number two, cupulolithiasis on the long arm side. Third is the periampullary restricted posterior semicircular canalolithiasis with partial canal gem, which is also called the SCOCO 2019 variant. The fourth is apogeotropic posterior semicircular canal BPPV. The fifth is short arm posterior semicircular canalolithiasis. Although now for the short arm posterior semicircular canalolithiasis, the treatment with bow and yaw maneuver and recently its adaptation by our own group, that is the prone, pitch and yaw maneuver, is being increasingly used. This is the article Andrea Castellucci published and I was one of the authors for the first time in August 2025. Thank you very much. I finished my talk here.